Good, lovely. Well, welcome to everybody, as I've already said, and we will get going now. But just before we start the session, I just want you to be aware of a few housekeeping bits. If you have any questions, could you pop these in the Q&A section throughout? So there'll be a 5 or 10 minute question and answer session right at the end for your questions to be answered. So do feel free to put them in as you go along. Don't hold on to them to the end, and we will come to them. And also, I just wanted to let you know that a recording of today's webinar will also be made available to all participants, and we'll get them to you at the end of shortly after the end of the session. So welcome to you all. So I think now we can get started. So you will know, I hope, that this is the first of a 3-part webinar series. This first one, how do we solve the problems like community mental health waiting times, which I'm sure is an issue for many of us. In this first session, we'll be discussing with some fantastic experts in the field who you should be able to see on the screen, and they will introduce themselves shortly, how we go about better understanding the importance of accurate waiting time measurement, and more importantly, the impact that this can have on outcomes if we can get this right, and the experiences for our service users. So I'm Lynn Hunt, and I'm the Chair of Southern Health NHS Trust. And we've got some great speakers here with us today. So I'm going to pass over to Mike so he can introduce himself.
Good afternoon, everyone. My name is Michael Watson. I'm Principal Consultant at Acumentice, but prior to that, I've worked in the NHS for around 20 years in a variety of roles, delivering elective care and shorter waiting times across providers and NHS England in acute care and mental health care. Alistair.
Thanks, Michael. Thanks, Lynn, and good afternoon, everybody. Nice to see you all. I'm Alistair Hughes. I'm a GP in Kingston in South West London. I also work as a nurse educator at Roehampton University and as a patient experience and improvement fellow at University College Hospital, London. I've got a particular interest in mental health. Thank you.
Lovely, thank you very much, both of you, and we will be hearing from you shortly. Just to say that this promises to be a really interesting discussion about this topic. I think it's vitally important as we move forward. So without further ado, I'll pass over to Alistair, and Alistair's going to take us through some service user stories. So over to you, Alistair.
Thanks, Lynn, and thanks, Michael and team, for the opportunity really to get involved with this webinar and talk about this really important topic. When I was learning from Acumentice a bit more about how there are differences in the way mental health trusts and physical health trusts manage their waiting lists, I have to say I was quite surprised, because I'd always assumed the way that waiting lists were managed was consistent across the National Health Service. So I thought, well, maybe that's my experience, so let me have a chat with senior colleagues. And I spoke to many senior colleagues, actually, including some GP leaders in South West London, and surprisingly, many of them were surprised to hear that mental health waiting trusts managed waiting lists differently to physical health trusts. I think all of us together were discussing how positive it is that this piece of work is going to be done to try and optimize those processes and have an impact on patient care. But my job today really is to set the scene from the patient's perspective. We know that mental health accounts for around 40% of all GP appointments and GP work. And we know as GPs, and I certainly know in my own personal experience with patients, that long waiting times for specialist mental health services can negatively impact patient care. And so I wanted to use 2 anonymized patient stories, and some of the identifying details have been changed, but the core features of the stories are true, to provide an insight both on the child and adolescent mental health service side and also on the adult mental health service side as to what it's like being a patient waiting for specialist services. So the first case is of a 7-year-old child who came to see me with her parents. She had a complex psychological and social history. So she had been adopted from her biological family, having been removed by social services for safeguarding concerns due to domestic violence. She'd been adopted into a very supportive and loving family, but had continued to exhibit quite challenging behaviours around difficulties with emotional regulation, sleep regulation, interactions with siblings and other children in the social environment between the sort of ages of 3 and 5. And on starting school around 5, things again became more challenging. She struggled at school, interacting with other children, and had a particular incident where physical violence and altercation with another child, or aggression rather than violence, led to her having actually to move school due to concerns about ongoing behavioural difficulties. And even in moving school, things had remained challenging. And so her new school had suggested, given the escalating difficulties, that she present to the GP for consideration of specialist referral. The parents were also struggling with supporting the child at home, and this was having an impact on their own mental health. And so we made an urgent referral to CAMHS, and rather sadly, a month or 2 later, they re-presented with the child. The behaviour was worsening still. They had received a triaging letter from CAMHS, but they hadn't received an appointment. And their concern was growing because behaviour at home was starting to have an impact beyond just the child. One of the parents had presented with depressive and anxious symptoms to their own GP and had been started on medication. And they were really at their wits' end as to how to support the child at home. And school had noticed worsening academic performance and really quite difficult behaviour in the classroom that they were struggling to manage and support the child at school too. So the parents came back to see me again. I sent another urgent letter up to the CAMHS service. And a week or 2, I think actually it was a month in the end, later, the parents presented again and said, look, we still haven't heard from CAMHS. We're really worried now. Things are really challenging. We're going to go and see a private specialist. We made a private referral. The child was seen within a number of weeks. The consultant psychiatrist made a diagnosis of attention deficit hyperactivity disorder, as well as emotional dysregulation. Some medication was started. A plan was put in place between the consultant, the school, and the therapist, a private therapist who had been set up. And the parents felt much better supported. And when I reviewed the child a few weeks later, she was much happier. She was calmer in the room. The parents reported much better behaviour already at home, and school were happy. And the child was starting to show improving academic performance. And the parents felt that their own mental health was improving as well as a result. So we can see how the impact of sometimes of waiting times can have a significant impact, not just on the patient or service user, but also on family, parents and the like as well. So that's our CAMHS example. If I move now to our adult example, so again, the details around this case have been changed to protect people's identities, but the core themes are true. So I saw, as an initial GP appointment, this 50-year-old man with worsening symptoms, really quite severe symptoms of anxiety. It's important to say that he had long-standing difficulties with an anxiety disorder, with a mixed anxiety depressive disorder, and had been on medication for some time. But his symptoms had been worsening despite that medication. And rather sadly, or very sadly, he had lost his partner traumatically to suicide a year earlier, and he had been the person to find her at home, the first person to find her. And he was having symptoms of anxiety with panic attacks, generalized anxiety, but also symptoms of a complex post-traumatic stress disorder. He was having flashbacks, nightmares, hypervigilance, and difficulty functioning in daily life, despite high doses of medication. And he himself felt actually he'd really benefit from psychological therapies and specialist psychological therapies, but was unable to seek those privately due to cost. And so we made a referral to the local IAP service, the Improving Access in Psychological Therapies service. They rejected the referral based on the complexity of the presentation, which was understandable, but that's the first point of referral. They asked us to refer to the secondary care mental health service. And so we did that. And we did that on an urgent basis, in part because of some suicidal ideation for the patient in question. And a few months later, the patient returned to say, I haven't actually heard about an appointment yet. I haven't heard any indication of whether I'm on the list for psychological therapies. Again, we sent a follow-up letter. Again, the patient returned a month later, having not heard about an appointment in secondary care mental health services. And in the meantime, the patient had been presenting to multiple GPs, to the A&E department 3 times, I think it was, in a period of 4 months, with what were felt to be anxiety and stress-related symptoms. So panic attacks, health anxiety, migraine headaches, chronic migraine headache requiring high doses of preventative medication. So again, we can see the impact of how the kind of long waiting times leading to accessing out-of-hours services and GP services appropriately in some cases. And we had been trying multiple medications without success. And the patient himself said to me, I feel a bit forgotten. I feel out there on my own and unsupported, and that really scares me. And we are still in the process of them waiting for their first psychological therapies appointment. So that just paints some of the issues we see in general practice. There are, of course, positive cases as well, but just to frame some of the challenges around waiting lists, I hope that's helpful. And I'll pass back now to Lynn. Thank you so much.
Thank you, Alistair. I mean, two very different presentations in patient presentations in terms of age and other demographics, and also outcomes as well. And seeing, for the first presentation, a swift referral, the outcomes that are so positive, and then for the second, this sense not only of somebody who's in clear distress, but also compounding the problem by making them feel kind of out there on their own. I think you said out on a limb. How do you, when you've got somebody like that who's still waiting, what can you do?
That's a really great question, isn't it? And I think in the end, we end up just being a listening ear and being a supportive place of safety where the patient can come. I think the frustration, certainly, I can't speak for all GPs, but speaking for myself, is that a 10-minute appointment is not enough for that. And so sometimes we end up running very late because you want to give these people space to express their distress, and they often are lacking spaces to do that in their social life as well. So although we can try different medications, certainly with complex post-traumatic stress disorder, I think it's providing a listening ear as an interim measure while they're waiting for a therapist who's obviously specially trained to manage these problems. But the patients appreciate that, but it's obviously suboptimal, isn't it? And they would love to be able to just get on and solve the problem. So that's often what we end up doing.
Yeah, lovely. Okay, so listening ear for a GP is very difficult in terms of the time that you have, etc. So appreciate that. So can I just remind everybody that if you've got any questions as we go along, please submit these in the question answer box, and we'll get as many of these answered at the end as we possibly can. I'm going to hand over now to Michael, who's going to talk about parity of esteem and where we currently are with waiting time. So taking those two stories, Michael, take us through your presentation, and we can look and see what some of the options are for the future.
Thanks very much, Lynn, and Alistair. Really quite moving to hear the impact that some of these long waits can have on people and their families and carers while they're waiting. So I want to kind of take a step back and talk a bit about the bigger picture before we get into the detail. So we often hear about the NHS waiting list and the backlog in the news and elsewhere, and it's currently the figure that's bandied around is around 7.5 million people. And reducing the waiting list is a headline commitment. It's one of Rishi Sunak's key promises and one of Labour's commitments, one of their missions as well. And they talk about paying doctors and nurses overtime to cut the backlog. But I think it's really important to emphasise that when people are talking about the waiting list and backlog, what they're talking about is the physical health waiting list for people waiting for their first treatment only. Even in physical health, that excludes many people who are waiting for subsequent treatments, people who are waiting for diagnostic tests, and people who might be waiting for follow-up appointments. And mental health is completely excluded from that figure. So when you've got the leading political parties making commitments about reducing waiting times, they're only talking, really, in terms of the figures that they're using, in terms of the commitments they're making, they're only talking about reducing waiting times for physical health. And we know, and not just from some of the stories that we've heard from Alistair, but also in terms of the impact about what it can happen to people who are on long waiting times for community mental health. A report was published, was leaked to The Independent a couple of months ago, which estimated that around 10,000 people died while they were under the care of community mental health teams in 2022-23, which is a shocking number and really another kind of indictment of the impact of waiting for a long time to access these services. So Department of Health and Social Care was asked by the Public Accounts Committee to set out what achieving parity of esteem for between physical and mental health would require. So first, parity of esteem, so equality between physical and mental health, had to be defined, which is what we're seeing on the screen here. So delivering parity of esteem, parity of timely access, evidence-based and therapeutic care, and patient experience for people with mental health needs. So once they defined what parity of esteem was and agreed the definition, then it's about what do you need to do to get to that point. And one of the key things was around improving the quality of data, making sure that data is on a par with physical health, with equivalent transparency, equivalent ambition of targets, equivalent urgency in delivery expectations, and equivalent scrutiny. Before I go into more detail about this, I think it's important that we're here today to talk about better systems for managing people through their community mental health pathways. Better systems is not a substitute for increased investment in estates and in workforce, although there is an entire other conversation about more modern workforce and delivery models. But all we're here to talk about today is how to make the best of the resources that we've got, and it's not taking away from the fact that those resources are often insufficient. So where are we now? So at the risk of stating the obvious, the reason why we're here today is that many mental health services have long waiting times to access community services. And as we heard from Alistair, and as we saw from that evidence that leaked the Independent and many other sources, how long we wait can significantly impact our experience and the experience of those around us, and also on our outcomes. In terms of information, given how important data was emphasised by Department of Health to the committee, there is a real variation in reported data across providers and ICSs. And in fact, where we are today, this variation is so great that we can say with confidence that the reported data in the public domain at the moment is not accurate. So fundamentally, we don't know how long people have waited to access mental health services. We know anecdotally that it's too long, but we don't have accurate information. And if we don't know how long people waited, we cannot act effectively to make their waiting time shorter. So I've worked across mental health and physical health in the NHS for over 20 years. And my observation is that consistently, many mental health systems are absolutely not ready to face the challenges and the expectations to bring mental health into parity of esteem with physical health. And it's worth emphasising, if we're talking about inaccurate data, this is just retrospective reporting, what's happened in the past. We'll talk in our second webinar on the 23rd of July about the improvement and transformation which can be unlocked through prospective tracking and management, forward-looking across the whole pathway, where we'll also hear from a working Chief Clinical Information Officer in a mental health trust about how effective some of these approaches can be and why it's so important in terms of making best use of what we've got. So we talk about parity of esteem and getting data up to where it should be. And I quoted in the previous slide the need for data on a par with physical health, equivalent transparency, ambition, urgency, and scrutiny. But what does that mean, and why is it important? There are 4 key benefits to improving data quality and using that to manage people more effectively. So firstly, it's around demand and capacity. Fundamentally, as anyone that's involved in improvement will tell you, if you can't count it, you can't improve it. We can't see which interventions have longer waiting times. We can't see which teams have longer waiting times. We can't see which population groups are experiencing unwarranted variation. So improving data quality and using that accuracy about understanding where everybody is on the pathway enables you to quantify bottlenecks and also to make the case for appropriate investment. Secondly, credibility with system partners. So many of you working in mental health providers will have had conversations in your ICB about money, because let's be honest, that's what a lot of people are talking about a lot of the time these days. And having the data to support conversations with your ICB at a parity level with acute partners is absolutely crucial to making sure that mental health doesn't play second fiddle. So being able to move away from the anecdotal, we feel busy and demand is rising, to something much more defined, like demand has risen by 13%, our waiting list has grown by 1,200 people. We've got a demand and capacity imbalance in CBT for psychosis, which requires an extra 3 whole-time equivalents. Being able to have that level of specificity in discussions adds credibility and increases the chances of securing further investment in mental health. And thirdly, just as importantly, is addressing inequalities. The NHS Race and Health Observatory has found that there are clear and consistent racial and ethnic inequality in access and outcomes to healthcare in the NHS. And we could see the impact of targeting particular groups with particular protected characteristics. For example, University Hospitals Leicester identified inequalities in DNAs linked to deprivation. They provided extra support to attend appointments and reduced DNAs in that target group to 1%. So having an understanding of your population is fundamental to being able to bring about improvements, and relies on having quality, robust data available. And then finally, supporting transformation. People who wait longer to access community services experience anxiety and uncertainty and are more likely to access crisis services, further exacerbating pressure on inpatient capacity and on out-of-area placements. And we heard from Alistair some examples of what that feels like for patients and for carers. I attended the NHS Confederation Mental Health Network event in Leeds back in April, and there's lots of discussion about the impact of long community waiting times, and a clear message that in order to reduce pressure on inpatients, we need to start in the community with focused, timely interventions. So, demand for community mental health services is growing, and the investment and staff required to meet this demand are not keeping up. So it's more important than ever to ensure that the systems and processes that we have in place to manage waiting lists and waiting times are making the most effective use possible of our staff and resources. I'll just hand back to Lynn for her reflections before we move on to the next stage of the presentation.
Thank you very much, Michael. One of the things that I think I've worked in health services myself for a number of years. One of the things that I notice is that no matter what funding comes into mental health services, they tend still to feel like a Cinderella services in comparison to some of the big bang, big new hospitals. That's the stuff that gets the attention. Let's have big new hospitals. Let's have big new pieces of kit, different ways of doing things. One of the things that strikes me about healthcare is what gets measured gets done, actually. They're very often. So if you set yourself a target, you'll find that suddenly there's a lot of money flows to that, sometimes at the detriment of other things. But actually having sight on these waiting lists could be hugely important in terms of the way that mental health services can respond to those waiting lists, and thinking about innovative ways of driving practice in a different direction sometimes to support more people. Have you got any thoughts about how we might put some leverage into the system to use the waiting lists to drive better options for people rather than just more of the same?
I think, it's a great question in a very big topic of conversation, I would say. But I think coming back to the kind of focus on data, certainly my experience of implementing shorter waiting times in physical healthcare, everything is driven in terms of that system level understanding of where the kind of hotspots are. Yeah. So the first, as I said, the first kind of part of any conversation about making improvement is understanding where you are now. So identifying where we've got particular pressures around particular interventions or around particular areas of need is really the kind of what underpins any kind of conversations, and using that data at a national and at a regional level to then focus conversations with providers about, like I said, about not just more resources, but about making better use of the resources. And as you said, making sure that we're providing the most effective interventions is absolutely key to then bring about improvement for service users. And one of the things that's really encouraging about the new waiting time standards, which I'll come on to talk about in a minute, is the kind of centrality of outcomes management as well as just process management. So making sure that people are not only getting something quickly, but they're getting the right thing quickly, and that the thing that they're getting quickly is as effective as possible.
Thank you very much indeed. Can I just remind everybody that if you've got questions, please put them down there in the question and answer section. It's really important. I'm going to keep moving with you, Mike, if that's okay. Just because we're time limited, and I know you've still got a lot to say. So can we go to part 2 of your presentation, and then we'll take some time at the end again to have some reflections.
Great, thanks very much, Lynn. Okay, so I talked a bit about the kind of policy side of things and why some of these things are so important. Now I'd just like to talk a bit more about process. And just a reminder, for today's session, we're talking about the high level process and how things are being progressed nationally. In subsequent sessions, we'll then be talking about what implementation looks like in providers, and also some quality improvement approaches that can help you to not just measure waiting times accurately, but also to improve things for service users and families. So how do we get to where we are now? So back in 2021, NHS England carried out something called the Mental Health Clinically Led Review of Standards. That part of that review heard a lot from service users and carers who were very closely involved, and they said that the time waited to get the right interventions is important to them, and that their experience is affected. And we know from anecdotal evidence, and also from some of the things that we heard from Alistair as well, that outcomes can be affected by long waits and deterioration, not just for the people who are waiting, but also for those around them. So as part of this review of standards, it was agreed that NHS England would move away from what we call contact-based metrics, so how long did you wait to get an appointment, towards understanding that there is actually meaningful activity taking place when someone has started to receive the help that they need. And that's a really key distinction. So in February 2022, NHS England responded to the CRS and set out a standard of 4 weeks from referral to getting help. So the expectation is that when someone gets referred, they should actually get help, meaningful help, not just an appointment or an assessment, that they need within 4 weeks. And as we heard anecdotally from Alistair, we're quite a long way from that point for a number of people who are presenting at the moment. And as you can see from some of the statistics on the slide, we're quite a long way from that in aggregate as well. Late last year, NHS England started publishing some kind of initial data just based on those appointments. So this isn't the full indicator based on understanding who's actually getting meaningful help. This is just about when you get your first appointment. As you can see, some of those early figures are quite shocking. So for children and young people, 10% of people are waiting over 32 weeks for their first appointment. And some of the longest waits are really very long indeed. And there are over 300,000 children and young people who are currently waiting for their first appointment. So a huge number. And if you think that 10% of those people, so over 30,000 of those people are waiting over half a year just to have their first appointment, not to receive what they need, but just to be seen for the first time. And similarly, it's actually a slightly worse picture for adults, where people are waiting, 10% of adults are waiting over 35 weeks for their second appointment, and over 200,000 people on the waiting list. Referring back to my previous slide, what we do know is that this data is not accurate. The extent of the variation across regions and across providers is so great that it cannot be correct. And if anything, I think the theory is that this is actually understating the scale of the problem. But anyway, that's where we are now. What we're looking to do in the future, as I described, is to move to a meaningful measure of what actually counts for young people and for adults. So as I mentioned previously, the initial contact is what's currently being measured, while we're moving towards these more meaningful measure of referral to treatment or referral to getting help. I'm not going to go into the detail of this today, firstly because there's a great deal of information available from NHS England about how that works, but I will just allude to it briefly because I think it's important to underline that it's a much more meaningful measure, but also it's a great deal more complicated for providers in terms of making sure that they're able to evidence what's happening. Everything that needs to be recorded and reported to NHS England to show how long people are waiting needs to be recorded using what's called SNOMED CT codes. I'm not going to launch into a detailed exposition of SNOMED CT codes at this point. It's probably another webinar in itself. But effectively, SNOMED is a clinical vocabulary which is used by EPRs, by electronic patient records, which includes codes for diagnoses, symptoms, interventions, and so on. There are millions of SNOMED codes. It's mandatory that all mental health trusts are able to record SNOMED codes. But the key to improvement and the key to getting it right is actually giving people, giving clinicians, giving teams, giving administrators a meaningful list of what the relevant interventions are for your particular pathways, aligned to what the needs of the service user presenting are. There's also lots of technical detail behind this in terms of how referrals into different teams as people move through the mental health systems are linked through quite a complicated algorithm. And finally, as I mentioned, the most important thing for service users and families is how long it takes them to get help. And the way in which help is defined, or getting help is defined, is very complicated. There's a diagram on this slide, which I'm not going to go through blow by blow, but fundamentally, getting help is about getting the right intervention, so getting an evidence-based treatment for the condition you're presenting for, which harks back to the definition of parity of esteem I mentioned at the beginning. Having an outcome recorded, and picking up on the question that Lynn asked earlier, it's important to understand not just how long someone waits to get something, but that the thing that they're getting is effective. And also having a contact, the kind of bare minimum of what we've been measuring for waiting times. So a lot of trusts these days are measuring their waiting time between first and second contact, although as we saw on the slide previously, many of them not reporting that accurately to NHS England. Some trusts are looking at waiting times in individual teams, but very few, in my experience, are currently tracking from referral to getting help. Just a reminder, referral to getting help is not just what's being measured for the future by NHS England, but it's also the thing service users, families and carers have suggested is actually important to them. And then finally, going beyond the NHS England standards, which really should be an absolute minimum, very, very few providers have visibility of subsequent interventions in a systematic and centralised way. So even those that are doing really well in terms of tracking that kind of referral to getting help pathway, once people get help for the first time, there's then the risk that they're lost sight of in a centralised way as they have subsequent interventions further down their pathway. So that's the hope for the future. So what's next? So this July, so next month, in fact, NHS England will publish the activity data from April. So this July, we will see the first cut or the first view of what waiting times look like from referral to getting help. So this is not data we've seen before, but it is something that NHS England have talked about in terms of management-only information and so on. And certainly from what I've seen, bearing in mind, as I mentioned before, that I used to work for NHS England, the proportion of people who have a clock stop recorded, so who have that kind of getting help definition recorded, that combination of activity and outcomes and intervention is extremely low, in the single figures. And fundamentally, the challenge to providers and systems is that in terms of the reported data, if you're not recording a clock stop, so if you're not recording that someone has attended something, that they've recorded an outcome, and that they've received a meaningful intervention or care plan, then your waiting list will grow and grow and grow. And I said before, people who are accessing services value getting help. They don't just value attending an appointment. So if you are in a provider and thinking, well, we are doing the right things, we do develop care plans quickly, we do take outcome scores, we do deliver evidence-based interventions, and if you're not recording that, then firstly, my challenge to you would be, how do you know that you're doing it for every person in a timely way if you're not able to record it accurately? And secondly, if you are doing all of those things, well done, but you are shooting yourselves in the foot by then not recording it and reporting it to NHS England in the way in which you need to do, because that information will be published next month. And fundamentally, what comes out from NHS England in terms of waiting times, that is your data, and that is how your waiting times are seen externally. And you will be held to account. Speaking of that held to account, so that kind of referring back to the parity of comment, that parity of scrutiny, one of the key planks in the NHS planning guidance for this financial year for mental health is that all systems are required to agree improvement trajectories for people waiting over 104 weeks. So this isn't what every mental health trust thinks are people waiting over 104 weeks. This is according to the new measure, according to referral to getting help, according to recording all of those key data items using SNOMED codes, everybody who looks like they might have waited over 104 weeks, there will need to be an improvement trajectory. But if people don't have the data to be able to manage that on a day-to-day basis and to be able to evidence it, then this will prove to be a real challenge. Managing by waiting times cohorts is an absolutely standard approach for physical health waiting times. In fact, I've just finished an assignment delivering this kind of elective recovery in an acute trust. We saw really significant improvements. And it's not a mystery what the approach is that's effective to deliver this kind of improvement. So what you need is patient level detail of everybody who's waiting, what they're waiting for, when they need it by, and reported every week at the very least, ideally live. What else is required is clearly defined timed pathways to identify where people are, where they're off plan, and also to identify any bottlenecks. Accurate, historic, weekly demand and current capacity so that you can model future needs and plan for the future rather than being surprised when waiting times start to increase. Complete alignment of internal reporting, so what you're looking at day by day, week by week, what goes to your board, with external reporting in terms of what goes via NHS England into the public domain. And then finally, within your organisation, clear escalation processes so that you can resolve potentially long waiting people before they wait a long time, not so that you find out that they waited too long afterwards. We'll talk a lot more about what these processes look like and how you can implement them and how you can make improvements in the next webinar. But I also wanted to flag that another key target in the planning guidance for March 2025, so only a few months away, is the full implementation of the Patient and Carer Race Equality Framework, PCREF. So it's an expectation that by the end of this financial year, every trust board is able to see metrics for access, experience and outcomes broken down by different protected characteristics, including ethnicity, and that includes your waiting times. So a further challenge, as well as getting the waiting times reported accurately, is making sure that you've got sufficient data quality and understanding of the different protected characteristics for the people who are waiting for your services so that you can be assured that people are getting equity of access. So, in summary, cannot emphasise enough the importance of realising that these waiting time standards are here, they're live now, and that your data will be reported in public. Fundamentally, it doesn't matter if you in a provider or a system think that the reported data is wrong. It is your data and you will be held to account for it by NHS England and by the public. There will be attention paid to the figures, and systems providers with the longest waits will be picked up. It will certainly get picked up by the HSJ, by the Health Service Journal, and it may well be picked up by your local paper, by the BBC. So notwithstanding the impact that we've heard over and again on service users, families and carers, there's also a reputational impact on organisations, because you can't just point at the figures and say they're wrong, because they're your figures and you are responsible for them. The next question is, are you ready to capture and report this increasingly complicated data? The new waiting time standards mark a step change in the level of data required to measure people's progress through their pathways and the systems that you need to have in place to record them. So, do you have those systems in place? Are you able to capture and report SNOMED codes? Are you recording them in a user-friendly way that makes sense to clinicians and administrators? Are you linking your referrals in the correct way to meet the requirements of the algorithm? And are you fully capturing and managing services along lines of protected characteristics? Because fundamentally, if you can't report it in the right way internally, you can't be managing it in real time. If you're only tracking people when they've already waited too long, you can't act to help them. So at the very least, is your board seeing your performance against the new definitions, or are they going to wait until it gets published by NHS England and comes out in the local paper? But fundamentally, if your board can't see what you're doing, how can they be assured that you're managing it effectively and you're able to improve it? And finally, in terms of PCREF, again, if your board doesn't see how access and weights vary across different ethnic groups and other protected characteristics, how do they know, how do you know that everybody has fair access to your services? So the solution, which we'll talk a lot more about next time, is effectively a single version of the truth for waiting times, what's called a PTL, a patient tracking list, which again we'll talk about on the 23rd of July. That's a single repository of everybody who is waiting in every team, whether they're waiting to get initial help or whether they're waiting for a subsequent intervention, all in one place, accessible to everybody across your organisation. With that, I'll hand back to Lynn for any final reflections before we move on to the Q&A section.
Hi there. Yeah, Michael, I just want to ask you one question. I'm sitting here listening to this. It's really fascinating, and I'm thinking about my own board, and you and I have had some conversations about the data that we do see and how some of it is a little bit illogical because of other movements. But one of the things that strikes me is every board will be part of a system, and every system then will have oversight of all of the waiting lists, thankfully, going forward, both in terms of the parity esteem around mental health and all of the other waiting lists that they will be working on already. And it's just really thinking about using the power of the patient story that we had right up front from Alistair, how we might get some more leverage around really focusing this very closely on individual patients and their stories. And Alistair, did you want to come in?
Yeah, I was fascinated listening to that detail, and certainly the conversations that we've had already. I think I feel so positive about the idea we might get more structured information on what is available in our community mental health service, what waiting times are for each individual specialist intervention, because people feel empowered. And I think certainly by people, by the way, I mean both clinicians and patients, certainly in the CAMS system locally in Southwest London, they have become much better at doing that. The patient and the family gets a letter saying, we've received your referral. This is where you are on the list. Please provide us this information. Here's some key resources you can use. And I know from what parents say to me, and young people who are old enough to understand, that is really empowering. You know, they love that structure. It gives something to hang their condition on, their situation on. They feel supported, and it's not even necessarily a person-based contact to begin with. So that's been really positive, and I think that would be so helpful. I think of that case of my the 50-year-old male who was really struggling with severe anxiety. Yeah. If he had a structure to say, we've got your referral, you're going to see a psychiatrist to triage you and make a treatment plan at date X, and you're going to get possibly this therapy, but this is the waiting time, he would feel, I think, more supported. He certainly said that in the past. You know, it's a case of just knowing where he is and what he should expect. That's really powerful for people. And it's simple, I hope. Well, is it simple, as Michael's been alluding to? It's actually quite complicated in the background, isn't it? But at the patient end, it seems simple, and it can be really helpful.
Yeah, it feels like a real game changer, I have to say. Just having the information out there and available, and we're able to talk about it and drive change, and boards focusing on it. A hugely important piece of work for us all. And but I don't want to lose sight of those patient stories, because in many ways they will be the narrative that sits behind this, if you like, the data with soul that actually says, and this is working, and the focus on this is working, and the way that we're producing the data is working for people and changing their lives. And I think that's where sometimes we lose the dialogue and the connection is relating it back to proper people and their journeys. So thank you ever so much. Now, I know that we've got time now for some wider questions and answers. So thank you for allowing me just to reflect that with the two of you. So shall we go to Lucy?
Hi, everyone. Yeah, thank you so much, Lynn. Yeah, we have had a question from Simon Bristow. So he asks, how can trusts understand which pathways are driving their long waits? In particular for CYP services, there are large neurodevelopmental waits in many places that may be being reported alongside other CYP waiting time data. So Michael, I don't know if that's potentially one for you.
Yes, thanks, Simon. So I've got two kind of answers to that question. On a practical level, before I address the particular neurodev issue, really it's everything that I've just talked about is kind of how to address that question. So getting an accurate idea about all of the people who are waiting in one place to give you as a provider or as an ICS the ability to analyse that data and see where the long waits are, whether it's for particular pathways like neurodev, whether it's for particular interventions on an individual pathway, so particular treatments, or whether it's for particular groups of people according to their protected characteristics. Having that underpinning is absolutely the key to improvement. And the fact that the trusts, as it's implied in your question, don't always understand where their longest waits are, really just underpins how far they have to go to get on top of this. In terms of the neurodevelopmental bit, I think there's a much more nuanced conversation at a policy level to have with NHS England, where, for reasons best understood only by themselves, there are different groups of people who are managing different parts of the services, particularly for children and young people, depending on the kind of presentation. So the neurodevelopmental pathways are managed separately, the ADHD diagnostic pathways are managed separately again, and then people with common mental health conditions are managed separately for a third time. So I think that there is absolutely, as you're flagging, a risk that by looking at these things in isolation, we're failing to see the bigger picture. But I think there's probably a policy side to that which we can't really address today. But from a process point of view, in individual providers, there is nothing stopping you, again, from having that single version of the truth, all the people who are waiting for something in one place, so that you can see where your hotspots are.
Lenny, I think you're on mute.
Schoolgirl error or what? Alistair, did you want to come in?
Yeah, I'm not sure I'm best placed to comment on that. I think that was a logistics and data-driven kind of non-clinical question. Really, I'm not sure I could have anything to add. Thanks.
Thank you. I just saw you pop up. I thought that's why you were.
Oh, no, that's very
appearing.
kind. Yeah, no, thanks.
Okay, Lucy, back to you.
Great, thank you, Lynn. We've got one more from Simon. Apologies, Alison, this is also directed to Michael, I think. If we think long waits are being underreported, what can trusts do to ensure they have assurance that their data is accurate? It sounds like this is going to be the main political priority, which I guess is timely with the upcoming election.
Yeah, thanks, Simon. And I think, again, that's kind of what I was trying to tackle, I guess, towards the end of my presentation, that both within your organisation, whether that's within a team or within a division or however it is that you're structured, but all the way up to your board, the crucial thing is to ensure that you're looking at your data in the same way that it's being viewed externally. So the way it's being viewed externally, I emphasised earlier on that it was complicated. I think there's a slight caveat to that. It's complicated compared to what's being done now. It's not complicated in reality. What we're saying is, for a large number of really quite expensive services, please can you tell us who you're seeing, what treatment you're giving them, and whether or not they're getting better. It's complicated, it's a step forward, but in terms of an actual expectation, if you step back, really, it's pretty minimal. I would say that's the bare minimum. In any other sphere of work, if you couldn't say who you were seeing, what they were getting, or whether it worked, then if you were running a company, it'd be shut down fairly sharpish. Anyway, so going back to the question, rant over, absolutely making sure that you're reporting consistently with what's going to be reported externally, so that you see it in your services in terms of managing people forward, and you see it in your board so that you know what's happening and you can feel assured long before it gets published 3-4 months later by NHS England.
Thank you. That's really, really helpful, Michael. I do like the challenge to us all about being able to explain where it is that we're putting our resources, and I think boards need to be better sighted on these things rather than just extrapolating everything up into one kind of service line. So thank you for that. Any more questions, Lucy?
We do have one more. Yes, thank you. Alistair, this one is for you, I think. And the question is, where do you think clinical priorities need to be?
Oh, that's such a great question, isn't it? And that's a big question. I guess we would want that to be data informed, because the kind of the danger of making these sort of anecdotal or personal experience based judgments. I mean, I can speak to my own experience. Certainly, the demand for a neurodiverse and neurodevelopmental assessments, both at the child and adolescent stage and also at the adult stage, is of course very large at the moment. And I think, as Michael alluded to, that's a slightly different conversation. I would pass back to him for the details of how those services are structured. But at the sharp end of general practice, certainly lots of adults are presenting, wanting a neurodevelopmental assessment for the possibility of undiagnosed autism spectrum disorders, attention deficit disorders. We've then got challenges around the provision of medication for attention deficit and hyperactivity disorders as well, and the shortages and supply issues that we face and having to manage those on a daily basis. From the perspective of mental health services, I would perhaps defer to one of my very senior colleagues, Claire Gerardo, who often talks about the provision of psychological therapies and increasing the numbers of people who are trained as psychological therapists, because patients, I think, are becoming more and more aware of the role of therapeutic intervention in managing common mental health conditions and the kind of empowering nature of getting to the root cause of mental health conditions themselves, be they traumatic experience in early life or more recently, or even just working with symptoms in the context of kind of cognitive behavioral therapy and working more skillfully at a psychological level with symptoms, and how that can be, in the end, far more beneficial for some individuals than medication. And certainly that's the conversation I'm having with longer term mental health patients who have been perhaps on medication for many years, many of them for kind of complex post-traumatic presentations. They are proactively coming to us and saying, I really want these evidence-based therapeutic interventions now, eye movement, desensitization, EMDR therapy, trauma-based CBT, because they're hearing from friends, from relatives, from other patients, so the power of those interventions for kind of long-term healing and recovery. So I think on a personal level, and it is just anecdotal, I would agree with what I've heard Claire speak about there, which is increasing the provision and access to psychological therapies. And IAPT's done a great work on that around the kind of more, how do we say this, kind of rapid access, short-term therapies, but trying to do that for perhaps more complicated patients, a little bit like that example of the 50-year-old male with significant complex needs. And I'd be interested in perhaps Michael and Lynn's thoughts and experience around the provision of longer form therapies at a secondary care mental health level, because we often see very long waits in primary care for those interventions.
That's a very small detail point there, Alistair. So just to be absolutely clear, the waiting time standards that we're talking about now are exactly that. So for CYP, it's for basically every intervention. For adults, because we've already got a waiting time standard for NHS talking therapies, as IAPT is called these days, and we've already got a waiting time standard for accessing eating disorder services for children and young people, and we've got a waiting time standard of 2 weeks for accessing first episode of psychosis. This is effectively the 4-week waiting time standard for everything else. So effectively, it's for, broadly speaking, adults who don't have common mental health disorders, which would be seen by an IAPT service or a talking therapy service. Therefore, those adults who do have some sort of more severe mental illness. That is the aspiration of this 4-week waiting time target, and that's very much the problem which we're trying to address.
Yeah, absolutely. And I think we have seen periodically with different pushes and movements from political parties, the need for better and well-funded long-term psychological services for people to offer support and treatment. And I think and when we see that, when these things come along as part of a treatment package, we see people improve and their outcomes improve as well, and them go on to make better life choices, etc., and lead fuller lives. So anything that highlights the fact that we've got deficiencies and in this area, I think will be better for everybody. So as I say, I think this is a game changer. I think it's a huge opportunity for us to flag something that is really it's gone on too long. We need to be able to look after the mental health of our nation and the people who need those services, and we need them properly funded and make them sustainable. Okay, so we've got a couple of minutes, literally, just to finish off with any more questions. Did I see Simon come again?
We've had one actually from Philip that has come through,
Okay.
and I think from his question, I think we maybe know the answer from you as individuals, Lynn and Alistair, but I guess perhaps more in the round and with people who you work with and more widely in the mental health sector. Philip's put a question asking you both, in your experience of working with clinical colleagues in mental health organisations, what are your thoughts on the appetite and engagement of those colleagues as the industry of data collection comes to mental health services?
Michael, did you want to go first, or would you like me to go?
No, it was definitely addressed to you, so I was going to try and tread on your toes, Alistair.
or Lynn as well. That's a great question, isn't it? I think certainly from colleagues, there's a varying level of enthusiasm. I think sometimes there's a bit of fear associated with these sorts of measurement-based interventions. Certainly, I think people have different views, don't they, on mental health conditions, but they're quite complicated, aren't they? As we all know, in many cases, they have many contributing factors, both social, psychological, and beyond. And I think certainly with my older school colleagues, they find some of it more challenging or the idea of measuring some of it more challenging. And I think that data sciences have clearly come an awful long way in the last 100 years, and I think it could be a really positive and interesting sort of journey to try and go about measuring some of the factors around. And of course, this work has been done, hasn't it, in the evidence around lots of these conditions, but making that more mainstream and certainly bringing it perhaps more into primary care as well, and trying to get more standardized measurement of symptoms even at the very beginning of presentation, not just when they move on to more detailed secondary care assessment. I think I'm also sensitive to the fact that colleagues talk a lot about burnout as well at a personal level. So, you know, the demand on secondary care mental health services from friends who work and colleagues who work there is large. And these are obviously emotionally challenging interactions in certain cases, not just for the patient, but also for the clinician as well. And working, I think, skillfully with the psychological impact as a clinician on your own emotions and your own energy professionally is really challenging. So I think whenever there are these large shifts in approach, there can sometimes be both a bit of fear, but also a lot of excitement. And I should imagine people fall into different categories. Certainly for myself and very local colleagues, there is a really positive feeling that quantifying need and available resources is a great next step, and actually is going to make us feel better, not worse, about what we're doing, because we're going to be really empowered to look specifically and intervene purposefully and purposively for each individual patient and have transparent and honest discussions. And that often leads to really rewarding clinical interactions. So it's a really big question. I think on a personal level, I'm excited. And for most of the people that we speak to, I'm excited. But I do know in the past that certainly for some professionals, especially if they're under a lot of pressure, there is sometimes a bit of fear and occasionally pushback against these sorts of activities and improvements.
Okay. Lovely. Thank you. So from my perspective, I think that we need to use data to improve our services. We need to, we can't possibly improve things unless we know what our starting point is. And that's where I find data hugely exciting, and driving our quality improvement programs when we see the data and making sure then that we're continuously improving our services on the basis of the data gathered. It shouldn't be seen as something extra and add-on. It's got to be seen as a core part of what we are expected to do, and demonstrating value for money as well. So although it's tricky, I do get that. But I think they're the basic principles. We've come to the end of our time. We've gone over slightly, but just by 1 minute. But that was a great question at the end about the balance there, about what people can do. So thank you very, very much to everybody who's been a part of this. You can see that you can keep your eyes peeled for part 2 on the 23rd of July and part 3, and that will be announced shortly. And thank you very much for coming along and sharing with us this morning. It's been lovely to see you all, and thank you.